All right, let's see if we can complete our talk about the female reproductive system. We had just finished talking about the lining of the uterus and the three layers, parametrium, myometrium, and endometrium. So now we're going to talk a little bit about the external female genitalia. And we already mentioned that the copulatory organ is the vagina, which is the root vagina means 8 for 8 centimeters long. So it's the copulatory organ, and it's also the birth canal. We'll get to a picture of it here in a second. So here's an anterior view of what we would call the female perineum. And let me go over and get my pointer here. So just like in the male perineum, it goes from the ischial tuberosities laterally up to the pubis up here. And it can be divided into the anal triangle or perianal area and the clinical perineum, which is up here. What we're looking at is the mons pubis laterally. The mons pubis being up here, and then the labia majora, the fleshy folds, lateral, and then the labia minora. Between the two labia minora, that's the area that we would call the vestibule. And at the extreme anterior end of that, we can see the protrusion of the erectile tissue called the clitoris. You go down below that a little posteriorly, and you get the external urethral orifice. And below that, you have the opening of the vaginal canal. And just lateral to the inferior part of the vaginal canal, we have the openings of the greater vestibular glands, which are the mucus glands that lubricate the vagina during the sex act. In some young women that are not sexually active, there's a thin epithelium that still covers the opening of the vagina, and that's called the hymen. This would have to be ruptured in order to have intercourse, but just because it's ruptured doesn't mean you've had intercourse. It can rupture just through daily movements as you get older. Let's see. So here we've taken away the skin, and we're looking at the bone. So there you can see this is the ramus of the pubis, and up here to the pubic symphysis. Extending down below that, that's the clitoris, and then we actually have the analogous structures to the bulb and the crus of the penis here. Embryologically, the clitoris develops from the same tissue as the glans penis. And just like the corpora cavernosa and corpora spongiosum, they have a bulb and a crus. So this would be the bulb here, and this would be the crus. And there you can see the greater vestibular glands. The posterior end of the vaginal orifice, again, it's called the vestibule. The posterior end is called the fourchette. And you can see the openings of the greater vestibular bulbs there. All right, we'll talk a little bit about the mammary glands, which are the milk-producing glands. We do have a model of this in lab we'll get out and take a look at. Really, what you should know is that most of the female breast tissue is adipose tissue, and it has these acini in there, which are arranged in lobules. And the lobules are the milk-producing glands, and they're modified sweat glands, actually. And they have a ductwork called the lactiferous duct, which comes anteriorly to the nipple, and it passes through a swelling where we have some muscular tissue in there, and that's called the lactiferous sinus. And then it goes out through a continuation of the lactiferous duct. So you have the lobule, duct, sinus, and then more duct. And then finally coming out the nipple, and the darkly pigmented area around the nipple is called the areola. The breast tissue responds during development to estrogens and progesterone, as well as the hormones prolactin, and I already mentioned estrogen and progesterone. So especially during pregnancy, when estrogen and progesterone levels go up relatively rapidly, the breasts swell and they engorge with milk. There are ligaments in here too, which I believe they are trying to show by these little white streaks. I think it's labeled in here. Yeah, the white labels and the white structures. They're called suspensory ligaments, and they're connected to the pectoralis muscles, and they're actually what are responsible for keeping the breast elevated. An older term for this, I don't think your book uses, they're called Cooper's ligaments. Because they do connect the breast tissue to the chest wall. When the breast is enlarged during pregnancy, these Cooper's ligaments can become strained and actually can cause a lot of tenderness and soreness in in the breast tissue. That's also why having a strong upper thorax elevates the breast a little bit, because the pectoralis muscle doesn't sag and it helps hold this up a little bit. And functionally, the breast tissue obviously produces milk to nourish the baby. A little bit about breast cancer, and we could spend 40 minutes talking about breast cancer. Breast cancer is one of the most common cancers of females. It says here, what is it, the second most common cause of cancer deaths in the U.S., the first being cervical cancer, of course. An estimated 13% of people will develop this condition throughout their life. If recognized early enough, the treatment is very, very effective. After it's metastasized, it's very, very deadly. So an interesting thing about this is a lot has been made about estrogen and its role in either promoting the development of breast cancer and cervical cancers or repressing it. And it turns out the story is very complicated. Women who have never become pregnant and never nursed at all are at a fairly high level, a fairly high risk rate of developing breast cancer. That's what it's talking about here, no pregnancies. On the other hand, if you become pregnant just once later in life and didn't breastfeed, that also elevates you and your risk of breast cancer. If you become pregnant and have multiple pregnancies and you breastfeed, then that seems to be very protective. If you become pregnant and the breasts enlarge and you don't breastfeed, then that seems to indicate or seems to elevate your risk of developing breast cancer. So it's a little bit complicated. But even with all that said, down here it says 70% of women with breast cancer have no known risk factors. So there's no familial history, there's nothing to do with the pregnancy issues, there's no known carcinogens that have been taken in. It's just a rapidly dividing tissue, and I think really most of your rapidly dividing tissues in the body, whether it's the skin or the liver or the pancreas or the intestines or, in this case, the breast tissue, the prostate, these tissues are all going to be fairly sensitive to development of cancers. All right, there are now, I think, 5 different genes that have been implicated in breast cancer. These are the 2 that have been known for the longest time, the BRCA1 and 2 genes. If you have these genes, you are very likely to develop breast cancer. So they give you 50 to 80%. Usually they recommend a mastectomy, which is the removal of the breast tissue if these genes are identified in your family. But again, this only accounts for, this is a fairly high number, they say 10%. I've heard as little as 5% for that. Mammography is the examination of the breast tissue, which women over 40 should have once or twice, every 1 or 2 years is what I'm trying to say. Okay, and I'm not going to talk anything else about that. Okay, to the physiology of the female reproductive system. Well, again, the name of the game here is going to be to produce a gamete and then come up with a way of releasing that gamete into an area where it can get fertilized by a sperm. And in a crude way, that's exactly what we need to do. We just need to produce an egg, get it into the female reproductive tract where it can find a sperm if they've been delivered to the female reproductive tract. As I mentioned before, you're born with a very large supply of oogonia, probably maybe as many as 40 million. And we know that those start to degenerate as you go to reproductive age. Now we know that there's, as it says here, that there's some evidence that perhaps we can regenerate some oogonia later in life. So who knows? If you teach us in 10 years, we may have a different story to tell. All right, the process of producing the female egg is called oogenesis, in contrast to spermatogenesis in the male. We start with the cells called oogonia, which are gametogonia, right? They're oogonia. They're going to give rise to the egg cell, just like the spermatogonia in the seminiferous tubules. The thing to remember about spermatogonia and oogonia is that these are diploid cells. These are like normal body cells with their full complement of chromosomes. So we have to divide them by meiosis in order to generate the oocytes. Once they get pushed into the pathway of developing by meiosis, we call them primary oocytes. And this is actually what happens before birth. Okay, the oogonia start down their meiotic pathway and they get arrested there. And that's what it's saying. Primary oocytes begin in meiosis, and then they stall in prophase 1, and there they sit until puberty. We'll talk about some of the consequences of that a little bit later. So as we mentioned, at birth we assume that we have a life supply of oocytes. And that says here, once you reach puberty, there's a change in the hypothalamus, how the hypothalamus responds to estrogen levels, and that actually starts off the female reproductive cycle, which can happen in early teens, late teens, sometimes even before the teen years now, but usually somewhere in the early teens. And a half a dozen or so primary oocytes begin to develop further, and they go through more meiosis. Only one of those is going to complete meiosis. The rest will be reabsorbed by a process called atresia. When we finish meiosis, we're going to wind up producing one egg or ovum and 3 polar bodies. Now, don't get confused here. It says when we get the secondary oocyte. Remember, the secondary spermatocyte or oocyte is what's produced after the first meiotic division, after meiosis 1. There are going to be 2 rounds of meiosis. So after the first one, we're going to produce one teeny tiny little polar body and one big secondary oocyte. The polar body may or may not divide again, giving you 2 more polar bodies. But the oocyte is going to divide by meiosis 2 a second time to give you another polar body and one big egg cell. All right, I'm going to deal with most of these things when I get to the pictures. Here we go. So what's going to go on here? So before birth, here are oogonia. So that'd be a pluripotent stem cell. And these are sitting in those primordial follicles. And then in response to just stimulation from the ovary, we go ahead and start into meiosis. And so that becomes a primary oocyte. It's still diploid at this point. It hasn't divided. But it's going to go through meiosis. So once it's triggered the meiotic pathway, so we go into prophase. So that's where the chromosomes condense. They've already been replicated. Nucleus breaks down. They go into synapsis. And that's an important point. The chromosomes, the homologs, go into synapsis. So think about this. That means that from before birth to puberty, and whenever this particular egg gets selected to develop, maybe when you're 13, maybe when you're 43. Those chromosomes are going to stay in synapsis that entire time. So we think they get a little fragile and they get a little sticky with the longer time that they're stuck in synapsis, and that may actually alter the way they disjoin a little bit. And that can lead to the loss or gain of an extra chromosome in the gamete, and that can cause what we discuss as aneuploid variation, when a fertilized egg and the zygote that it becomes has either an extra chromosome or is missing a chromosome, and it's heavily dependent on the age of the mother. And we think it's related to how long the egg has spent sitting here in synapsis in prophase 1, waiting to develop. So there we are, we're arrested. At that point, we're what's called a primordial follicle. And then, once you get to puberty, and we start going through the ovarian monthly cycle, half a dozen or so of these primordial follicles are stimulated by FSH and LH from the pituitary to go ahead and continue developing. So that primordial follicle starts to thicken a little bit, and we get a few more cells around the outside, and we call that a primary follicle at that point. The egg starts enlarging, and we see those follicle cells get much, much, much bigger. The next step that happens is the follicle starts to form multiple layers, in which case, once we see multiple layers, we call it a secondary follicle. Now, the follicle is just the diploid ovarian support structure. It really is not derived from the egg. It's just ovarian cells. So we have our follicular phases, and we have the phases of the egg. The phases of the egg are simple. It stays as a primary oocyte until just before ovulation, where it then becomes a secondary oocyte, and there it stays until after ovulation, and it won't finish meiosis unless it gets fertilized. So the follicle is thickening, and as you might imagine, the follicle is thickening in response to increased FSH levels from the anterior pituitary. FSH, follicle stimulating hormone. This is how it got its name. So it's driving the development of this thickened follicle. The secondary follicle, then some of the cells split, and we have inner follicular cells and outer follicular cells. Once we have multiple cell layers in the follicle, these cells can also be called granulosal cells. So we have inner granulosal cells and outer follicle or granulosal cells. And the inner and outer is separated by a fluid-filled cavity that's developing. So that's why this is called a vesicular follicle. A vesicular follicle is just an enlarged secondary follicle. Some people call that opening there, that clearing that's full of fluid, they call that the antrum, so they call this an antral follicle. So you can have a vesicular follicle, which is the same thing as an antral follicle, which is just a maturing secondary follicle. Okay. Meanwhile, this is still a primary oocyte the whole time. Now, just prior to ovulation, the oocyte actually finishes meiosis 1. So that's where the homologs that have been paired this whole time now separate. And we get the first polar body generated, and we get the secondary oocyte that's produced. And this happens just a day or so before ovulation. And that happens still within a secondary follicle. At this point, it's called a Graafian follicle. It's a mature follicle, which means it's about to be ovulated. So they're kind of showing that. Now here they actually showed it ovulating. That's not quite a mature follicle. The antrum would be much, much larger. So just before ovulation, that's when we finish meiosis 1, and we have the discarded polar body, and we have the secondary oocyte. And remember, when we ovulate the egg, it'll be a secondary oocyte. It won't have completed meiosis yet. The polar body, if it has enough cytoplasm, the polar body may actually have enough energy to go ahead and divide again, and that'll give us our fourth polar body. Now, once we have ovulation occur, we release the egg. It pops out of the cortex of the ovum, gets swept up into the fimbriae and the ampulla, the fimbriae and the infundibulum of the ovarian tube, where it might encounter a sperm. If the sperm does fuse with the plasma membrane of the egg, then that kicks off a set of reactions that trigger the egg to go through meiosis 2. So meiosis 2 only completes if the egg gets fertilized. If the egg doesn't get fertilized, it just stays as a secondary oocyte that doesn't complete meiosis. If it gets fertilized, it completes meiosis 2, and again, it's asymmetric cytokinesis, asymmetric division of the cytoplasm, and then that gives us the secondary polar body and the ovum, which has already been fertilized. Meanwhile, back in the ovary, we're not quite done with that follicle. So the follicle released the egg, and so that will come over here and gets fertilized. But the follicle itself, these granulosal cells that are in here, some of them expand and turn yellowy, and they become luteal cells. And the luteal cells form a body called the corpus luteum. And the corpus luteum's job is to now synthesize progesterone. And the progesterone synthesis from the corpus luteum will be maintained for about 10 days. And that progesterone, its main job is actually to maintain the functionalis layer of the endometrium in its thickened state. And as long as progesterone is being produced by the corpus luteum, the endometrial layer will be maintained. And remember, the endometrial layer is going to be able to support the implantation of a developing embryo. So we can keep the progesterone levels up for 10 days. You might recall I said that the fertilized egg has to develop, well, now it's called a zygote, has to develop for about 6.5 more days in order for it to be able to implant. So the timing works out pretty well. We develop the zygote until it gets to a stage called the blastocyst, at which time it can implant. That's 7 days down the road. Ideally, the corpus luteum has been maintaining the endometrial lining this entire time, and so it's like chocolate and peanut butter. You got the two perfect things coming together. And we can have the egg implant, or the zygote. It's not a zygote at this point, sorry. The early embryo called a blastocyst can implant, and when that happens, the embryo will start releasing a hormone called human chorionic gonadotropin, which will in turn actually cause the corpus luteum to be maintained. If no implantation occurs, you don't get any HCG, so you get no signal to the corpus luteum telling it to be maintained, so the corpus luteum degenerates. Thereby, progesterone levels drop, and the dropping progesterone levels are actually what cause the functionalis layer of the endometrium to be shed, and we enter into what's called menses. So here's a compare and contrast slide between oogenesis and spermatogenesis. So as I mentioned, in spermatogenesis, the division of the cytoplasm is even, so from every meiotic event we get 4 viable sperm. Now in reality, it's been estimated that nearly half the sperm that are produced are retarded and don't actually function properly. So while it says 4 viable sperm, that's the most we could possibly get. It's such a rapid process that a lot of the sperm are malformed. Here they give you a very low rate of error. They say 3 to 4%. In reality, that's probably quite a bit higher than that. Oogenesis, so this is variable cytokinesis, that's the division of the cytoplasm. So we get one big gamete, ovum, and potentially 3 polar bodies. You'll always get at least 2 polar bodies, but that first one may or may not split. So you may just get 2. Now it says here the error rate for oogenesis is at 20%, but that really takes into account all oogenesis of all ages. The error rate goes up much, much, much higher in women after 40. And the polar bodies in females aren't thought to contribute anything to the process. They just degenerate, which is different in, say, plants that do this sort of thing. The polar bodies frequently are maintained and function in nourishment of the endosperm, which is what we eat as fruit. Okay, so what's going on in the ovary? So we have what's called the follicular phase, ovulation, which is mid-cycle, and then the luteal phase. So the follicular phase, that's when we're developing the follicle, where it goes from primordial to primary to secondary, and then the secondary goes through its phases, which are considered vesicular, antral, and Graafian. Sometimes that Graafian follicle is referred to as a tertiary follicle, and I think maybe your lab book uses that terminology. The follicular phase takes roughly 14 days, so the whole female menstrual cycle is considered to be 28 days, and any female will tell you that it's not always 28 days. Sometimes it's a little bit more, sometimes a little bit less. Every woman has a slightly different cycle. But on average, we'll say 28 days. For the first 14 days, the follicle is developing. At day 14 is when we think ovulation typically occurs. And then from days 14 through 28, that's when the corpus luteum is the corpus luteum is functional, producing the progesterone. And we'll correlate these ovarian cycles to what's going on in the uterus in just a little bit. Okay. Okay. So here I have some histology pictures, and we have a very nice slide of a cat ovary that looks really just like this, so we'll have a chance to look at these. You don't get the scale here. The primordial follicles, this would be viewed on 400x power. These are very tiny. So these primordial follicles at the beginning of the follicular phase will be selected, and about a half a dozen will develop as primary follicles. And then after a few days, the primary follicles, you can see this follicular layer on the outside, which is currently just one cell layer thick. That'll expand and become a couple of jumbled cell layers thick, and at that point we call it a secondary follicle. Now, all the time in here, this is just a primary oocyte. That's the egg right in there. And so it's really not doing a whole lot right now. It's still stuck in prophase 1. And is from primordial through primary all the way up to developing into a secondary follicle. So these granulosal cells, they start to form little cavities or pockets as they move around, and that's the beginning of the antrum that's forming. So that's turning this into a vesicular follicle. And now here you can see the enlarged follicle, the enlarged antrum. So this would be a Graafian follicle, a mature vesicular follicle. This would be the one that is sometimes also called a tertiary follicle. Now, a few things to point out. Okay, once we get to this point, we have an inner granulosal layer here, and those are just follicular cells that are stuck to the egg. These are actually going to be ovulated with the egg, and that's called the corona radiata, those inner follicular cells. Now, they won't get fertilized, but they do have a role to play in slowing down the sperm as they are trying to enter and attack and ultimately fertilize the egg. Then we have a proteoglycan-containing layer that surrounds the outside of the egg membrane. That's called the zona pellucida, just means light layer. And then we actually have the oocyte in here. And again, at this point, it's still, well, we're not quite sure when this is. This is probably still a primary oocyte that's about to go through and finish meiosis 1 and become a secondary oocyte. And I don't see a polar body, so that probably hasn't done that yet. Just before ovulation, this guy will finish meiosis 1 and it'll generate a polar body, which would be a little nugget off to the side here. Then let's come out here. We'll pass through the antrum. The antrum's job is just to fill with fluid, and that actually creates pressure that's going to make this herniate out the side and cause ovulation. Then we get down here and we have the outside follicular layers. So this darker layer right here, these are called granulosal cells. And then we come out here, it gets a little bit lighter. And you can see kind of a light tissue here and then a dark tissue there. Well, these two layers out here are called the theca, and the theca can be split into a theca interna and a theca externa. The theca externa is smooth muscle and connective tissue, so it doesn't really have any kind of physiological developmental role. That's the theca externa. The theca interna, however, processes androgens and converts them into estrogen, and then the estrogen is used by the follicular cells. Well, let me correct that. The theca internal cells process androgens other than estrogen, feed that to the follicular cells, and the follicular cells convert that into estrogen and secrete estrogen, and that's what drives up the large amounts of estrogen. These cells are responding to FSH signaling. In response to FSH signaling, they become more sensitive to stimulation by the theca internal cells, and so there actually sets up a positive feedback where you get a little bit of estrogen being produced. The estrogen causes the theca externa cells to become more sensitive to their androgens, which then they produce more of, and the follicle, in response to FSH signaling, is becoming constantly more sensitive to that, and that accelerates the development of the follicle. Positive feedback between the theca interna and the granulosal cells. All right, there's some more pictures of it. Each follicle. So when ovulation occurs, roughly at day 14, the buildup of fluid inside the antrum, which is triggered by LH secretion from the anterior pituitary, fluid builds up in there, creates hydrostatic pressure, which actually makes the egg herniate out the side of the ovary wall. So we ovulate the egg along with the corona radiata cells attached, and some people claim that they can actually feel that when ovulation occurs, and the name for that is Mittelschmerz, which I kid you not is a real word. It just means pain in the middle. So some people claim that they can tell when they ovulate. Obviously, being a guy, I can't speak to that, but my wife claims that there are times where she thinks she can. It says here, all right, so sometimes, a low percentage of the time, we may actually ovulate 2 oocytes, ordinarily just 1. And interestingly, ordinarily, the ovaries, the right and left ovaries, take turns. So 1 month the right ovary goes, next month the left ovary goes. I don't really know how they communicate that, but that's typical. If you have one of the ovaries removed, the other ovary just takes over and goes once a month. So I find that kind of interesting that they manage to switch on and off, and they're apparently aware of their twin over there. Speaking of twins, if you do ovulate more than 1 egg, then you have the possibility of fertilizing both of those eggs with sperm. And if that happens, then you have non-identical twins, or what are called fraternal twins, which is different than identical twinning. Identical twinning would happen if 1 egg gets fertilized, and then in the early embryonic development, called the germinal period, it splits. And if it splits, then you get 2 identical individuals produced. Okay, so after ovulation, I mentioned that these granulosal cells and the internal thecal cells that are left over in the follicle form the corpus luteum, which secrete progesterone and a little bit of estrogen. And the job of that progesterone is to maintain the functionalis layer of the endometrium. So after about 10 days, the corpus luteum breaks down and becomes scar tissue, which is simply called the corpus albicans. And then I mentioned down here that if implantation of an embryo occurs, one of the things that happens is that early embryo secretes human chorionic gonadotropin, which causes the corpus luteum to be maintained, which then causes the corpus luteum to keep the endometrial layer maintained. And that is responsible for keeping the endometrium in place and capable of supporting the development of the fetus for the first 3 months. And after that, the placenta has gotten large enough to take over the secretion of progesterone. And at that time, the corpus luteum can break down. Okay, so guys, I've stopped there. The next PowerPoint actually deals with, let me see if I can find this. The next PowerPoint deals with the relationship between what goes on in the ovary, what goes on in the uterus, and the phase of the follicle development. And there's a graph that shows all three of those. And I'm not going to record another video showing that. If we need to do that when I get back, that's fine. We'll do that on the Monday when I return. But what I wanted to show you while I'm here, let's see, oh, sorry, it's under course documents, I believe. There are a couple Khan Academy videos that I went to and I watched, and these are actually really good. I'm trying to think where I put them. I think they're under, oh, yeah, I put them in the I think I put them in the PowerPoints folder. So we come down here to reproduction. Here we go, okay. You'll see here we have the ovarian cycle, the reproductive cycle, and the second half of the reproductive cycle. These videos are almost identical to what I lecture on this topic, so I thought they have nice illustrations rather than just being redundant and saying, hey, go watch these videos. Since you're watching a video anyway, I thought it might be just to have you watch those videos. There's a short answer section on your final that deals with the types of topics that are talked about in these videos. Specifically, the correlation between what phase of the follicle development we're in, what phase of the ovarian cycle we're in, and what is the uterus doing during these phases, and what are the hormones doing? Specifically, how is the hypothalamus responding to estrogen and progesterone differently in the proliferative phase versus after ovulation in the luteal phase? Okay. So watch those videos, and hopefully you have enough to keep you busy until I get back. Okay. Thank you so much for your patience, and I hope everything's going well, and I will see you on Monday.